Good afternoon to all the participants in this conference. My name is Oscar Camacho. I'm a medical doctor. I am an anesthesiologist, emergencist, and also a diving and hyperbaric medicine. I work in the north of Portugal, in Porto, in the hyperbaric medical unit. I start by greeting the two other members of the panel, Mark and Tino. It's very challenging for me to talk in the same panel that they talk. I would like also to thanks to the organization for inviting me, and of course thanks to Arlindo, and congratulations for this initiative in organizing this important event, an incredible event that is Diving Talks. So, as a doctor, I need to talk about COVID-19, I know, and my presentation, my talk is about post-COVID-19 underwater world. I know you are all fed up with this pandemic and with the impact that caused in our lives. It will be more nicer to talk about another subject, but I think we cannot do like the ostrich and put the head inside the sand and ignore what happened and is still happening. So my presentation has three goals: the magnitude of the problem of COVID-19 provoked in the recreational diving community, how it is diving during the pandemic, and some concerns about fitness to dive after COVID-19. Scuba diving, we know it's a passion for many recreational divers and also represents a critical component of the diving industry. These are numbers of this publication of DIMA, the 2021 Diving Fast Facts, and you can see there is a lot of active divers around the world, 2.7 to 3.8 in the US, and there's almost 6 million active divers worldwide. And there is also about 11 million snorkelers in the USA and more than 20 million snorkelers worldwide. So there is a lot passionate people for diving. We also that recreational diving is a popular sport that had its beginning in the early 50s, after Gagnon and Cousteau built the first diving regulator. And in the next decades, in the next years, a lot of, many people have begun to dive, and like any other passion, a lot of people continue to dive. So this, nowadays, we can find an important number of aging divers and also older people that are beginning to dive. This is very challenging for us, medical community, because these people could have, and have, a lot of them, the typical and unusual chronic disease of our current society. We are talking about cardiovascular disease like coronary artery disease, high blood pressure. We are talking about endocrine disease like diabetes or high cholesterol. We are talking about respiratory disease, and some of these divers perform complicated surgery. And a lot of them are taking a lot of medication that could interfere with the human physiology when we are in the water. So it is very challenging for us to evaluate these divers. So with all these people, what is the risk of dying from the recreational diving activities? According to the DAN annual diving report, the risk is very small. We are talking about 1 point deaths per 100,000 divers per year. Here in Portugal, a diver that drives to his diving club to dive, the probability of dying is almost 40 times bigger. So you can see, you can compare how it is, the risks. So the common factors that are associated with these fatalities usually are insufficient breathing gas, the panic, and a rapid ascent, a malfunction or problems of the diving equipment. And if you look for the cause, for the cause, you see that the leading cause of death is drowning. This is the cause that is confirmed by the doctor in an autopsy. And the disabling injury that led to death usually is the cardiovascular related problems. So, with this picture, with all these divers from all over with all these ages, I have this question. Do you think that recreational divers need a medical certification? I ask to the audience who is in favor of a medical certification that put the hand in the air. Okay, you can put it down. Who are against the medical certification? Oh, what's a relief, I still have my job, thank you. So, how we do that depends on the country. In some countries, the divers and the candidates to a diving certification must complete a medical certification and go for a doctor. In the other countries, they fill a questionnaire that you already know is a questionnaire like this. This is the more consensual questionnaire. This is adopted by many diving organizations, which includes Divers Alert Network. And after fill this questionnaire, an evaluation by a physician is required in these two options. If we have positive answer, or if the participant is engaged in the professional diving leadership training or a certification program. I believe that some of you have filled this questionnaire before the COVID-19 with all negative answers. But I also believe that if you fill the questionnaire today, this first question was positive. And this first question is if I have had problems with the lungs or I have been diagnosed with COVID-19. And if you tick an yes, you must go to box A. And in the box A, the last question is I have had a diagnosis of COVID-19. And if you put yes, you are kindly advised to search for medical evaluation. So, now is the moment to summarize in 4 slides all the immense published information about the pathophysiology of the COVID-19. So, we all know this, that COVID-19 is the name of the World Health Organization given to this disease. This disease is caused by the coronavirus SARS-CoV-2, which means severe acute respiratory disease by coronavirus type 2. The transmission is primarily spread from person to person by respiratory droplets that are emitted by asymptomatic, pre-symptomatic, and symptomatic patients. Most of the transmission, 40 to 50% of the transmission is by asymptomatic and pre-symptomatic patients. So we believe this could be the main reason, or one of the main reasons why a disease that begins like an endemic disease in 2019 in China quickly became a pandemic. So this is a picture of the pandemic published by the Johns Hopkins University 4 days ago. 4 days ago was 5 of October 2021. I choose 5 of October because for us in Portugal is an important date. For those who are not Portuguese, 5 of October is the day we implant our republic. We send our king away. So this was 110 years. It's a good day because it's holiday, so we can go for a dive. As you can see also in the dashboard, in this 5 of October we had more than 235 million of cases around the world and almost 5 million of deaths. In this day in Portugal we arrived to 18,000 deaths. So How we get sick? We breathe and inhalate the virus with the respiration. The virus travels and goes until the pulmonary alveolus. Inside the pulmonary alveolus, this is the configuration of the virus. This spike, which is a glucoprotein, binds to these physiological receptors, that is the angiotensin converting enzyme 2, the ACA. And this complex enters in the human cells. This is the mechanism how COVID-19 enters in the human cells. Once inside the lung human cells of the alveolus, the cell will be infected. Once infected, the inflammatory cells came, and the inflammatory cells and the virus begins to produce the pro-inflammatory cytokines, what we call the inflammatory storm, the cytokine storm. After that, the free cells, the virus, enter in the circulation in the blood, travel in the blood, and goes for searching for other organs with high ACA expression. This ACA receptor exists under normal conditions in a lot of organs. In the left side, on blue, you can see where the ACA receptors exist and function under normal physiological conditions. On red, on the right side, you can see when this receptor is disrupted by the coronavirus. Let's see two examples. The first one, in the brain, it participates in the normal cognitive and memory function. During the disease, we can have cognitive and memory impairments. In the oral cavity and tongue, it participates in the regulation of taste sensitivity. Under the disease, we can lose our taste. That's what we call ageusia. It is not good for a wine lover like me to have this symptom, I believe with you also. So we can find it in the other organs, heart, kidneys, lungs, pancreas, gastrointestinal tract, and there is a lot of scientific publication at this moment about the effects on these receptors. One paper that was published last week by the New England Journal of Medicine shows an increased amount of diabetes type 1 because it influences the beta-2 Langerhans cells in the pancreas, and this is responsible for the new cases of diabetes type 1. This is a schema published in the New England Journal of Medicine that shows the different clinical scenarios, the different severity of the disease that could range from asymptomatic or pre-symptomatic. You have patients that are positive, have a positive test, but no symptoms. You have mild illness that are patients that have fever, cough, changing taste or smell, but they don't have dyspnea. Until the other side, that you have the critical illness and you have the multi-organ dysfunction. Note, please, that the critical illness is more of the responsibility of the inflammation from what we call the cytokine storm. So after this fast pathophysiology of the COVID-19, what are the concerns for us divers and the relevance for diving? This is a chest CT scan of the patient number 2 that was admitted in my intensive care unit in the 23 of March 2020. This patient number 2 is my friend, is a diver, sometimes he's a buddy diver, and he had more than 75% of the lung with the disease. And this is a typical image of the COVID-19 disease. You can find ground glass opacities, crazy paving pattern, consolidations, more often the peripheral than central consolidations. So, regarding these acute pulmonary effects, what is the mechanism of injury? We have mainly two mechanisms. One is related to the inflammation, and the other is related with the mechanical ventilation that these serious patients could need. And of course, majority of these patients have or had bilateral disease. So with these acute problems, what will be the long-term pulmonary effects? The reality is that the chronic phase has not yet been described, but we have one hypothesis that it is similarly to the other coronavirus. We already have two outbreaks of coronavirus. The coronavirus 1, 2002 in China. During these 20 years, a lot of studies have been made. You have another outbreak in the Arabian Peninsula in 2012, and also with the Middle East respiratory syndrome, and a lot of studies have been published. About SARS-CoV-2, these are two studies that show the effects on the acute phase and in the chronic phase. In the acute phase, after 3 months, 20% of the patients had these changes in these exams, a normal pulmonary function test and the normalities in the chest radiography. And the follow-up of 15 years of these patients show that we have a rapid improvement in the first year, and then after that we have a plateau, a stable of the pulmonary function tests, whatever the improvement the patient has. So our question is, does COVID-19 behave similarly? We believe so. And we know also this COVID-19 is seriously infected more, and the inflammatory response is higher. So it's possible that residual lung disease may have potential implication for divers. So these long-term effects of the lung could be this one: a decreased compliance that results from the residual fibrosis or scars, and the structural abnormalities like bull or bleeps. We are talking about the possibility of a residual air trapping. So this is a possibility of this disease. Divers may be exposed to increased risk of barotrauma and have a decreased exercise tolerance. But more, it's also possible that this residual lung disease could interfere with the pulmonary small vessels and allow that asymptomatic venous gas bubbles cross the capillary filter and the arterialize. This is one possibility. So this theoretically could happen. Another effect of the residual lung disease, this is a question we don't know, if increases the sensitivity of the pulmonary tissue to the toxic effects of oxygen. We don't know. But this is a question, and after this question comes the other question. Should technical divers be more conservative with the hyperoxic mixtures? We don't know. We are studying this, we are following this. There is some societies around the world that alert to be more prudent, but we don't know. We don't have scientific evidence of this. We know that COVID-19 is an atypical pneumonia, but as have you seen, we have ACE receptors all over in a lot of organs, so we can have other organs involved. One of the main organs involved in the serious disease is the heart. And in hospitalized patients, the cardiac injury occurs in 20–30% of the patients and is responsible for more or less 40% of the deaths. And the effects are two. We have direct effects, it's the virus that goes inside the myocardial cells, and we have indirect effects due to the cardiac stress of respiratory failure, the hypoxemia, and also the hyperinflammation. And these patterns of injury in the cardiac, in our heart, could be the elevation of cardiac biomarkers, what you call troponin, an acute coronary syndrome, some arrhythmias, inflammation of the heart, myocarditis or pericarditis. We don't know the real incidence of this cardiac involvement in patients that had mild or moderate illness, because during the pandemic, as you know, the health service were pushed to the limit. So these patients with mild and moderate disease, they stay at home, and until now we don't know what is the impact of this. Regarding the small vessels, the effects of cardiovascular effects relevant to the diving, we know, and this is proved, that we have virus invasion of the endothelial cells, as you see. We have inflammation, disruptions of the endothelial cells, edema, and this predisposed to the prothrombotic state. So, another question. We know that decompression sickness causes endothelial dysfunction. Could this have implications for decompression sickness? Another manifestation that we see in COVID-19 is the thromboembolic disease. In the acute phase, as I told you, we have an hypercoagulable state. So this predisposes to the venous thromboembolism and the acute coronary syndrome. But of course, like the other effects, the chronic effects are still unknown. But these specific effects, direct effects, are very unlikely. But we must be aware of this, that decompression sickness is an inflammatory and prothrombotic acute disease. But, as I told you, complications that these patients had during the disease, like acute coronary syndrome, pulmonary embolism, or taking anticoagulant therapy, needs medical evaluation. So, how is diving during the pandemic? We know that diving activity almost stopped during the outbreaks, and now, depending on the epidemiologic situation and the local public health, we are back to a new normal. But we cannot forget that SARS-CoV persists in the community, and that's the reason why the diving organizations have published recommendation of risk prevention and mitigation. This is an example of a document published by Dan about COVID-19 and diving operations. Is the 10 recommendations of prevention. You can, for example, if you want to know what to do in a medical emergency, you go to the chapter 8. And these are generic measures that we must still keep in mind to avoid the spread during the diving operation. Continue the social distance, disinfect private and rental equipment, and avoid exchange of personal breathing systems. Of course, if you have an emergency, you must share the equipment. That's true. So, when you want to evaluate a candidate, this is very challenging. Why? Because the natural history of this disease currently is unknown. So we use recommendations based on the knowledge of similar conditions like pneumonia or pulmonary fibrosis or pneumothorax, and we also have in mind the limited specific knowledge of COVID-19, and also have present that there are different forms of diving, and some conditions may be disqualifying and others not. When we perform the diving evaluation, we have this also in mind. The acute physiology could be relevant to diving because we have an increased susceptibility to this diving disease that come from the cardiac, pulmonary, and the hematologic events that the patient could have. And about the long-term sequelae, we have this also in present. This patient could have, or this diver could have, a decreased exercise tolerance, susceptibility to cardiac events like heart failure, and could have this, it's a reality, structural change in the lung. So this is important to be aware that this is dynamic, this is not static. Every day's information, scientific information, is published. So this is always changing. This is recommendations of the COVID-19 that Dan published it, and says that divers who have tested positive for COVID-19 but are asymptomatic should wait at least 30 days before diving. Those who have symptoms should wait 2 months. And you have the other two groups that are divers that have been hospitalized with pulmonary symptoms or cardiac symptoms. They should wait 3 months and then be evaluated by a diving medicine specialist. And this is what we do when you come to search our help or our evaluation. The history, we do it in every patient, the physical exam, and depending on what we see, what we found, we can choose one of these examines: spirometry, chest radiography, echocardiography, exercise tolerance, or an additional evaluation if we need so. But this is important. As with any illness, the final decision on what to do is left to the description of the evaluating physician. The physician. So you're asking for us, medical doctors of work in this field, what is exercise tolerance? The diver must have returned to his or her baseline level of exercise tolerance, and the physician must be satisfied that the diver's exercise regime warrants an appropriate exertional test for diving. And we know that diving is different for each one. This is another tool that we can use, that is the metabolic equivalent test. This is an objective measure of the expense of energy when performing a specific physical activity, and is compared with the standard. And the standard is when you are quiet at rest, like you. In this moment, you are spending 1 MET, 3.5 milliliters of oxygen per kilo per minute. So, 1 MET, if you walk 3, if you fast run 12, sexual activity 5, don't be enthusiastic because this is at age of 22. So this is when you are diving 6 or 7, and we have also some guidelines that we use in the recreational. We need at least 6, and in commercial 17. So this is my last 2 slides about the COVID diving after the COVID vaccination. Most of you, I think, have already been vaccinated. So the side effects occur 48 hours following the vaccination, sometimes in 7 days. And of course, they are more frequent in the second dose. And this is, you can read some of the side effects. The serious side effects, as anaphylaxis, are very rare, and when it exists is at patients of risk, like asthmatics. So, when to dive? A minimum period of 7 days after each dose, and wait at least 14 days if the side effects persist more than 2 days, and if you belong to one of these risk groups, like excessive body weight, smoking, chronic metabolic disease, or taking medication that is interfere with the thrombotic. So this is my last slide. This is a nurse of my intensive care unit. I know she has a beautiful eyes, but she's holding a cellular, and you can see the wife and the daughter of my friend after 60 days in intensive care, and they are communicating for the first time, because as you know, they must be in the negative pressure rooms and could not receive visitors. Thank you, good dives, and sorry to spend more than 25 minutes.